Welcome back, everyone. Today, we're tackling an absolutely massive topic in vascular medicine. It's one that affects millions globally, and honestly, it's got incredibly high stakes if it's missed. We're talking about peripheral vascular disease, which you'll also hear called peripheral artery disease, or PAD for short. We're going to decode the entire clinical picture today, straight from the source material. Okay, let's dive right into this and really nail down the essentials.
To make all this complex info really stick, we've set up a super logical flow for this explainer. We'll start with the etiology and risk factors, move on to clinical features and signs, then we'll walk through the stepwise diagnostic investigations, and finally, wrap up with a comprehensive treatment plan.
So, what exactly are we dealing with here? By definition, peripheral vascular disease is the atherosclerotic narrowing of arteries supplying blood to the extremities. Usually, we're talking about the lower extremities, the legs, though it can absolutely happen in the arms too. The massive keyword I really want you to focus on here is atherosclerotic. You see, this isn't just some mysterious isolated leg problem. It is a systemic plumbing issue. Plaque is building up and literally physically restricting oxygen-rich blood from getting to the tissues that need it the most.
All right, Section 1, Etiology and Risk Factors. To truly grasp how to treat this condition, we've got to start at the cellular and systemic level to understand what's actually causing this narrowing in the first place.
Now, what's really interesting here is how perfectly this mirrors a totally different disease state. Look at the atherosclerotic causes: smoking, diabetes, hypertension, dyslipidemia, age, and chronic kidney disease. Well, those are the exact same risk factors for coronary artery disease. Basically, if a patient has plaque in their heart, you should assume they have it in their legs and vice versa. But we also have non-atherosclerotic causes to watch out for. The absolute highest yield takeaway here: thromboangiitis obliterans, also known as Buerger's disease. If you see a young, heavy smoker presenting with severe extremity ischemia, Buerger's should literally be flashing in neon lights in your mind. Other non-atherosclerotic causes include vasculitis, fibromuscular dysplasia, popliteal entrapment, radiation, and even trauma.
Moving on to Section 2, Clinical Features and Signs. Now that we know what's setting the stage, let's step into the exam room. How do these vascular changes actually show up as physical symptoms when a patient walks through your door?
The classic hallmark presentation of PAD is intermittent claudication. You can think of this as angina of the leg. The patient is going to describe a very reproducible pain or cramping, usually in the calf, thigh, or buttock, that only happens when they walk a specific distance. Why? Well, because the exercising muscle demands more oxygen, but that narrowed artery just can't deliver it. When they stop and rest for about 2 to 5 minutes, the demand drops and the pain goes away. But if this disease progresses, we enter some truly terrifying territory: critical limb ischemia. This is when the blood flow is so incredibly poor that the tissues are literally starving even at rest. The patient will complain of terrible forefoot pain, especially when they're lying flat in bed at night. Ironically, it gets a bit better if they hang their foot over the edge of the bed so gravity can pull some blood down. If left unchecked, this progresses straight to non-healing ulcers and frank gangrene.
When you're examining this patient, you're essentially playing detective with their circulation. The most essential clinical signs start right with the pulses. You've got to check the femoral, popliteal, dorsalis pedis, and posterior tibial pulses. In PAD, these are going to be diminished or just completely absent. You'll also likely see dependent rubor. That's a fiery red discoloration when the leg is hanging down, which happens as those maximally dilated capillaries get flooded with pooled blood. And I highly recommend getting familiar with Buerger's test. You just elevate the patient's leg, and if the sole of their foot goes pale, well, the test is positive. It means the arterial pressure simply isn't strong enough to pump blood uphill against gravity. Over time, this chronic oxygen deprivation paints a very specific picture on the limb. You'll start to notice chronic skin changes, hair loss on the extremities, skin that appears uniquely shiny and atrophic, kind of paper-thin, and thickened, brittle nails. What's happening is the body is essentially rationing its limited nutrient supply. It completely shuts down non-essential functions, like hair growth, just to keep the underlying tissue alive.
So you've taken the history, you've heard all about the claudication, you've seen the shiny, hairless skin, and you can't feel a strong pulse. The clinical picture is loud and clear, right? But here's the million-dollar question. How do we definitively confirm this diagnosis objectively and actually quantify the severity of the blockage?
That brings us to Section 3, Stepwise Diagnostic Investigations. We can't just guess at the severity here. We need hard, actionable data. So let's look at the logical pathway every clinician has to take to prove their suspicions.
So the absolutely crucial point here is this specific number.
an ankle brachial index, or ABI, of less than 0.90. The ABI is your undisputed 90% sensitive first-line test. It simply compares the blood pressure in the ankle to the blood pressure in the arm. In a totally healthy person, they should be roughly the same, so the ratio is around 1. But if the pressure at the ankle is less than 90% of the arm, meaning an ABI of less than 0.90, you've just officially confirmed the diagnosis of peripheral artery disease.
But we also absolutely must be vigilant for another threshold. If you run that ABI and the number drops below 0.40, the whole tone of the conversation changes immediately. An ABI less than 0.40 indicates severe PAD, placing that patient at an incredibly high risk for imminent tissue loss and critical limb ischemia.
Let's see how this actually plays out in clinical practice. We always start non-invasive. Step 1 is that resting ABI we just talked about. But what if the resting ABI is totally normal, yet the patient swears up and down their calf hurts when they walk? Then you move to step 2, the exercise ABI. You get them on a treadmill, and if the pressure drops after exercise, bingo, they have PAD. Once that's confirmed, step 3 is a duplex ultrasound to actually visualize and localize where the stricture is. Steps 4 and 5, the CTA, MRA, and formal angiography, are generally reserved for when you're actively planning a surgical intervention. We definitely do not jump straight to invasive angiography just for fun. It's the final step on the staircase.
Now, while we can get a little obsessed with imaging the plumbing, we cannot forget the systemic markers. You've got to run bloods. We need an HbA1c to check for diabetes, a full lipid panel, and a creatinine level, because kidney function is going to dictate what contrast agents we can safely use later on. And here's a really fantastic clinical pearl for you. If your patient is unusually young and presenting with PAD, always check their homocysteine levels. Hyperhomocystinemia is a sneaky but incredibly potent catalyst for early vascular damage.
All right, Section 4, Comprehensive Treatment Plan. We've identified the risk factors, we've recognized the clinical signs, and we've confirmed the diagnosis. Now, how do we save this patient's leg and, more importantly, their life?
Management here is strictly divided. First up, we have universal medical therapy. Every single PAD patient gets this regimen because, remember, we are dealing with a systemic disease. Looking at our first pillar, the top priority is crystal clear: smoking cessation. It's the single most effective intervention we have, period. Moving down the list, they need an antiplatelet. And notice this: per the latest ESC 2025 guidelines, clopidogrel 75 mg monotherapy is actually preferred over aspirin for PAD. They also need a high-intensity statin to crush that LDL down below 55, an ACE inhibitor or ARB to protect the vessels and reduce broader cardiovascular events, strict blood pressure control below 130/80, and if they're diabetic, an SGLT2 inhibitor is highly recommended. You see, you aren't just saving their leg with these meds, you're actively preventing their future heart attack or stroke. Once that universal baseline is firmly set, we treat the specific symptoms. For claudication, the grade A absolute gold standard recommendation is supervised exercise therapy. This is literally having the patient walk through the pain to force their body to build new collateral blood vessels. Pharmacologically, we can use silostazol, which dramatically improves walking distance by vasodilating and inhibiting platelets. But a huge flashing warning sign here: silostazol is strictly contraindicated in patients with heart failure. Finally, if the claudication is completely disabling despite medical therapy, or if they've crossed that threshold into critical limb ischemia with rest pain or ulcers, we escalate to surgical revascularization. That means utilizing endovascular angioplasty or surgical bypass to physically restore the blood flow.
We've covered the etiology, the classic presentations, the strict diagnostic criteria, and the complete medical and surgical management of PAD. But as we wrap up this explainer, I really want to leave you with a bigger picture reality. Look at the current global trends. With rates of diabetes absolutely soaring, coupled with rapidly aging populations all over the world, the math is undeniable. Are our clinical systems truly prepared to handle the massive impending wave of critical limb ischemia? Mastering the identification and aggressive early management of this disease isn't just good clinical practice anymore, it is a vital public health necessity. Keep this whole framework in mind the very next time you're checking pulses.